Welcome back everybody, David here again with Med School Bootcamp. In this next video, we are going to talk about autosomal recessive polycystic kidney disease. So previously we talked about autosomal dominant, now we're talking about autosomal recessive or ARPKD. And the same background applies here. We're dealing with a polycystic kidney disease. So a lot of cysts are developing around the kidney. This is going to cause kidneys to be enlarged, and it's also going to cause some problems for the patient as well that we'll talk about. So when we think about the pathophysiology here, we're dealing with an autosomal recessive mutation in the PKHD1 gene on chromosome 6. This is our first important contrast with autosomal dominant. So we have recessive here. We also have a different gene in a different chromosome. Do you remember from the previous video what gene was affected in autosomal dominant polycystic kidney disease? That's right. In autosomal dominant polycystic kidney disease, we have PKD1 and PKD2 with chromosome 16 and chromosome 4 respectively. And here we have PKHD1 on chromosome 6. So that's an important nitty-gritty thing they'd like you to know on test day. Now, when we talk about the presentation here, there's going to be a lot of similar findings with autosomal dominant. However, the key point that I mentioned in the last video that holds true here, this is typically going to present in childhood. We said that autosomal dominant or adult polycystic kidney disease is more likely to show up in people later on in their life, in their third, maybe fourth decade. But autosomal recessive, we're thinking about childhood or even in utero. Now, these patients are going to present with a variety of different things, one of which can be hypertension. We talked about this in the previous video. As these cysts get larger and larger and larger, they can actually compress the vasculature around the system, right? This can activate the RAS system, leading to more sodium retention, more water retention, and hypertension. So as children who have hypertension should raise a flag already. That's unusual for a child to have hypertension. There's only a handful of things we need to know at this level that can present with a child having hypertension. This is one of them. And I think it's particularly important to note that this can be unresponsive to monotherapy. So a child who has hypertension is on a hypertensive medication and it's still not working. Well, this should raise flags for some additional research on the patient's condition. Now, this can also present with things like oliguria and classically Potter's sequence. So you recall from way back, one of our first videos, what is Potter's sequence? Well, Potter's sequence is a constellation of anatomic findings that occurs when a patient has oligohydramnios in utero. A memory aid that we like to use for Potter's sequence includes using the word Potter, which stands for pulmonary hypoplasia, oligohydramnios, twisted face, twisted skin, extremity deficits, and renal failure. And essentially this is due to oligohydramnios, or low urine output in utero. The fetus actually gets compressed against the placenta, and that is what we suspect is playing a role in the developmental anomalies here. Now, just like autosomal dominant, these patients can also develop chronic renal failure as well, right? Things continuously get worse. If we're not doing anything about it, the kidney can fail in the end. Associated findings is going to be really important here for contrasting this with autosomal dominant, right? We talked about autosomal dominant. You can see hepatic cyst, pancreatic cyst, or intracranial aneurysms are the most commonly tested ones. Here, it's going to be the hepatic fibrosis. And so don't get confused. If they talk about a lot of hepatic cysts, they're probably pointing you towards autosomal dominant, but use the whole clue, right? If it's a 60-year-old patient or a 40-year-old patient, it's probably more likely to be autosomal dominant as well. If they're talking about fibrosis in a 3-year-old, then they're more likely to be talking about autosomal recessive. Now, what happens when fibrosis occurs in the hepatic system? Well, you're likely to get portal hypertension. This can also lead to possible liver failure. So again, both of these polycystic kidney diseases are going to have significant liver involvement. So the two key things you need to differentiate them is what is the liver involvement? Is it fibrosis versus cyst? Also, the age of the patient is going to be super helpful. Now, there is another condition that we should have on our differential diagnosis in a young patient with liver problems and liver cysts, and that is multicystic dysplastic kidneys. And so if you draw your attention here to the bottom, multicystic dysplastic kidneys is another thing that can present in a young child with kidney deficits. But there are some distinct key differences that I want you to be familiar with. One, this is non-hereditary. We're talking about autosomal recessive versus something that occurs more sporadically. Also, this is typically going to be a unilateral condition versus autosomal recessive is most likely to be bilateral. And finally, multicystic dysplastic kidneys are more likely to regress and resolve spontaneously. This is unlikely to occur in autosomal recessive polycystic kidney disease. So if they give you two similar presentations, like of a 5-year-old with kidney problems and high blood pressure, yes, these are both types of cystic kidney diseases, but these are 3 keys that I think are useful for telling them apart in a question stem. Now, moving on to our diagnostics here. This is going to pretty much echo what we talked about in the previous video on autosomal dominant, right? Same things apply here. Best test to use is going to be an ultrasound. You're going to see bilaterally enlarged kidneys with multiple cysts of equal sizes. That's a key differentiating point. We said in autosomal dominant, they're typically going to vary in size, but in autosomal recessive, they're typically going to be equal sizes. So keep that in mind. You can also do some other things such as a CT if the ultrasound is unclear, and you can get genetic testing, although again, this is not routine. And finally, moving on to the management for this condition. Similar to autosomal dominant polycystic kidney disease, we're going to be doing symptom management. So we're going to be doing things like ACE inhibitors, angiotensin receptor blockers for the hypertension, and to slow the proteinuria and progression to end-stage renal disease. We can also consider using tolvaptan, which can be useful for slowing renal cysts, but also for decreasing water reabsorption. If these patients have a severe condition, dialysis is always going to be on the table. However, the only curative option here is to do a transplant, a renal transplant, again, because this is a genetic condition. We can't actually treat it. We can manage it. But if we were to do anything that was treating it, it would have to be an organ transplant. Now, how is this going to present in a question stem? Well, they might talk about a young patient, a child, right, who presents to the emergency department because his parents noticed that he had some protrusion in the abdomen, a mass of sorts. The parents go into the emergency department to get it checked out. The patient's vital signs come back and he has a blood pressure of 150/94. The parents are unaware, but this patient clearly has hypertension. Now you ask the parents about the family history and they say they don't know of anyone that's had kidney problems in the immediate family. So in order to work up this patient, you decide to get an ultrasound, which shows some small cysts being developed in the kidneys bilaterally. Now they might ask you, what's the most likely condition for this patient? And the answer here is autosomal recessive polycystic kidney disease for several reasons. One, ultrasound showed bilateral involvement, right? This is different than our unilateral involvement we would expect to see in multicystic dysplastic kidney disease. The parents report an unknown family history of kidney disease. Because it's autosomal recessive, the immediate family might not show the characteristics. They might be carriers of the gene and not show symptoms themselves, but they both passed on the recessive gene to the child who now is a presenter of the disease. They have both the recessive genes. And that's why there's not necessarily a family history versus autosomal dominant. We would expect to see that family history. So there's lots of clues in that question stem, right? A young child with high blood pressure, abdominal mass, and cysts on their kidneys are likely to lead us to autosomal recessive polycystic kidney disease. Now, quick summary of this video. Autosomal recessive, we're talking about a condition that is different than autosomal dominant. The genes that are involved, the chromosomes that are involved are also different. This is most likely to present in childhood versus autosomal dominant, more likely to present in adulthood. Key associations I want you to know here. Potter sequence, right? If a child has this in utero and their kidneys are not developing or they're cystic, they're not creating enough urine, they can have oligohydramnios leading to the Potter sequence finding. Also, hepatic fibrosis, compare that to the hepatic cyst and the pancreatic cyst that we see in autosomal dominant polycystic kidney disease. When we think about our workup here, our diagnostics are going to pretty much be the exact same. We're going to look at an ultrasound, most likely, could consider a CT, could consider genetic testing, although those are not needed necessarily. For management, we're doing symptom management, similar to autosomal dominant polycystic kidney disease, ACE inhibitors, angiotensin receptor blockers, tolvaptan, because the only definitive treatment is to actually give these patients a renal transplant.